Hi, good afternoon, everyone. You guys can hear me?
Good afternoon. Good afternoon.
All right, I'm just gonna share my screen and we're gonna start the lecture, okay? All right, everyone can see my screen? Everyone can see my screen?
Yes, sir.
Okay, all right, cool. So today we're gonna talk about conjunctival lesions that are important to you. Just a little introduction as to what exactly is the conjunctiva. And we're going to talk about the signs and symptoms that patients will exhibit when they present with conjunctival pathology. We're going to look at infections, inflammations, some degenerations that are of salient importance to you, and we're going to look at this term called subconjunctival hemorrhage. Okay, so what is the conjunctiva? The conjunctiva is that transparent mucous membrane that we all see when we pull down on the lower lid to expose the inferior fornix, or we evert the lid to expose the back plate of the upper lid. But it actually extends from the upper eyelid margin on the back surface of the upper eyelid up into the superior fornix, across the bulbar conjunctiva or the anterior of the globe when you open your eyes, that area between the two lids, and it goes down into the inferior fornix and goes all the way back up to the back surface and of the lower lid and then the lower eyelid margin. All right, so it's the anterior surface of the globe. It has a rich vascular supply. As you know, it's supplied by the anterior ciliary arteries and the palpebral arteries. And the lymphatic drainage is important as well. If you remember from anatomy, the conjunctiva will drain down to your preauricular and your submandibular lymph nodes. So as I tried to describe in my definition, there are three anatomical parts to the conjunctiva. You have the palpebral part, which is the back surface of the upper and the lower eyelid. Then you have the fornix or the fornicial conjunctiva, which are the pockets just right up at the base of the upper lid and the base of the lower eyelid. That little pocket is called the fornix. And you have the bulbar conjunctiva, which is that space between the upper and the lower eyelid that you see. So that's the first membrane that you will hit when anything goes towards the globe. Okay? So it goes through the tear film and then it lands on the conjunctiva. So what you're actually looking at is not just the sclera, you're looking at the conjunctiva, which is transparent with a rich vascular supply, and behind it is the sclera, which is the opaque white structure that you see. Okay? So when a patient complains of conjunctival disease, they tend to have these signs. I'm trying to see my pointer. So everybody can see. You can see my pointer, right?
No,
So
Lord.
on this chart, you're not seeing it? Yeah, let me try again. Oh, laser pointer here. There, you seeing that now?
Yes.
All right, so on this side, you have the lacrimation, the grittiness. These are the symptoms: the lacrimation or increased tearing, grittiness, stinging sensation, burning sensation. Patients will describe itching as well. And the symptoms that these patients tell you can actually give an indication of what is actually wrong with the patient just by taking a history, okay? Now on this side of the page, you have the signs that you will see. So patients will have hyperemia, and in hyperemia, all you have is dilation of the blood vessels. So you have dilated conjunctival vessels, and it gives the eye this diffuse redness. Okay, so the redness is not localized to one zone. It's a diffuse redness. It can actually be located in one zone depending on where the pathology is. But hyperemia is when you have dilated blood vessels, and it gives that red aspect to the eye. Okay, so it can actually be generalized, localized, or it can be circumcorneal. All right. So when you do the lecture with me again about uveitis, you look at circumciliary injection. So Corneal means it goes in a 360-degree pattern around the limbus. So that would be when you have circumcorneal hyperemia, okay, where it's concentrated around the limbus. So it can be generalized, it can be localized, or it can be circumcorneal, okay? So another sign that you'll see in conjunctival disease is discharge. So discharge can have various characteristics. It can be watery, it can be mucoid, or it can be mucopurulent, all right, or just purulent. Now, depending on pathology again, you will see different characteristics. For instance, if you have a bacterial conjunctivitis, you'll expect to see a purulent discharge. If you have an allergic or a viral conjunctivitis, you will expect to see a watery discharge, okay? So when the patient has a discharge, it's important to ask them what the characteristics are. And hopefully, if you're lucky, you will actually see the qualities of the discharge in front of the patient if they haven't cleaned up the eye very well and come to you, all right? So another thing you'll see is papillae. Conjunctival diseases cause papillae. So papillae is another vascular response, but there's a raised lesion of edematous stroma, and it's centered by a blood vessel, okay? So the papillae in conjunctival disease can be giant papillae, or they can just be regular sized papillae, all right? When they're very giant and they have a certain appearance, they're called stone papillae. And I have a picture of that later on for you to see. And all of these you can actually see at the level of the eyelids. If you flip the eyelids, you can see it. And depending on the pathology, all right? You can also have papillae, giant papillae, for instance, can be located around the limbus. Sorry, not giant papillae. Papillae can be located around the limbus in an entity called, for instance, vernal keratoconjunctivitis, or the papillae can generally just be at the level of the tarsal conjunctiva, all right? So you can also have membranes when the patient has a conjunctival disease. These membranes can be true membranes, or they can be pseudomembranes. Now, how do you tell the difference? When it's a true membrane, it's very adherent to the underlying tissue. So if you see a membrane and you try to pull it off, and it's a true membrane, you'll see bleeding along with you pulling off the membrane. But if pseudomembrane, it's not very adherent, and once you pull it off, it's just going to come off easily without any bleeding of the conjunctival vessels behind it. All right? You can have your lymphadenopathy, or you can actually have scar tissue in the eye. Scar tissue in the eye is very important in entities like trachoma. But when you have these chronic and continuous inflammatory responses to conjunctival disease, you will start to see cicatrization of the conjunctiva. You can actually start to see blood vessels growing onto the cornea and certain levels of corneal opacity. The conj itself can grow onto the conjunctiva, carrying the conjunctival blood onto the cornea, sorry. So if the conjunctiva grows onto the cornea due to chronic inflammation, then you can have, you tend to have a lot of cicatrization as well, all right? And right, so these are some of the signs that you will actually see when you examine a patient with conjunctival disease, all right? So moving on, let's look at these infections. What are some of the infections that you can have in the eye? So when you have infections, you call it a conjunctivitis. When you have inflammations, depending on the cause, you can also be called a conjunctivitis. So we're going to go into the infections here. I put here infections and inflammations, but infections would be specifically bacterial, viral, and I went into a little bit more specific, like chlamydial. I'll go into a few more in terms of the infections. So let's look at what is a simple or acute bacterial conjunctivitis. So this is actually the most common ocular disorder that patients will present with. Okay, the etiology is usually the common pathogens in any other part of the body. So you have staphylococcal epidermidis, staphylococcal aureus, streptococcal pneumoniae, and Haemophilus influenzae. Okay, these are the most common pathogens that tend to cause a conjunctivitis, a bacterial conjunctivitis. So what happens is the patient will have direct contact with infected secretions and then touch the eye. All right, so then they start to have the symptoms of redness, grittiness, burning. They will have a discharge which will be purulent in nature, and they'll have conjunctival injection, and it usually can involve both eyes. It doesn't mean that it needs to be symmetrical in both eyes, but usually both eyes are involved, okay? So the patient will come to you looking somewhat like this, where they'll have, you see where this is the upper eyelid, this is the lower eyelid, and the distance here is the thickness of the eyelid. So you see that there's eyelid edema, upper and lower here, to the point that in the left eye, this patient can't open his eye spontaneously. So that's one of the symptoms of a bacterial conjunctivitis that can actually make you confuse it with an orbital or a preceptor. Okay, so the patient will not normally be able to open their eyes, but the swelling is a lot worse in a cellulitis, preceptal or orbital. Okay, so eyelid edema, one of the differentials is a bacterial conjunctivitis. You notice that there are other signs of infection and inflammation here because the patient has the erythematous tone of the eyelids here, okay? So they can't open the eyes spontaneously. The eyes swollen shut. The eyelids themselves are swollen. When you look at the lashes tend to have discharge or crusting on them, okay? And if you look closer, you can actually see the nature of the discharge. Here in this patient, you can see the purulent discharge, okay? So now the difference with that and a preceptal or orbital cellulitis is that when you're able to open the patient's eye, you'll see other signs. We're not going into preceptal and orbital, but just conjunctival inflammation, okay? So when this patient opens their eyes, what you will see is the symptoms that we described before in terms of the diffuse hyperemia, which can be either around the limbus or it can be a diffuse appearance of the whole entire bulbar conjunctiva. You can see a little bit of now you can actually see, you may see a little bit of the whiteness on the conjunctiva. You can see true membranes. Sorry, not true. You can see, this is an example of exudate or discharge that is so thick that it actually forms a little lining in the pockets of the fornix. Okay, so that discharge is what you're going to see when the patient has bacterial conjunctivitis, and you can actually see some membranes forming there. All right. So what do we do? It's important to debulk the eye of secretions. So in managing these patients, you tend to want to tell them to do a lot of eye care. We call it eye hygiene. So you ask the patient to use warm water and cotton and wipe away the secretions from the eye often. So they're not going to use the same moist cotton ball for the right eye that they use for the left eye, okay? So you dip it in the warm water and you just clean away. We like to use, well, I personally like to use moist cotton or Q-tips to wipe away secretions because there's less abrasion on the skin surface if it's a little wet. But you do it once and you throw it away and you use another one to do the other eye. And you do it often in the day, like 3 or 4 or 5 times, or as often as needs be. Because what you are looking for is that the eyelashes need to be nice and loose with no discharge, no matter clinging to it, because then it causes it's a nice home for bacteria. So you're trying to debulk the eye of secretions, let them stay open, and just wipe away the secretions. Tend to want to use antibiotics such as chloramphenicol, ofloxacin. So there are topical antibiotic drops of a wide variety that you can use for bacterial conjunctivitis. You must treat it with antibiotics, okay? You can also use an ointment if you want to, but I tend to use ointments more at nighttime because ointments tend to form a film over the eye and they tend to stay on the eye and the surface of the eye a bit longer. All right, so this is how you'd address your simple or acute bacterial conjunctivitis. All right, let's look at a specific type of bacterial conjunctivitis caused by Neisseria gonococcus. All right, so gonococcal conjunctivitis is a vernal infection, all right, caused by the Diplococcus. What tends to happen is the patient will have a history of sexual contact, and within 3 to 5 days of that sexual contact, you'll see them starting to develop symptoms, okay? Now, you can also get it in children, but I have a separate section for that. So what you tend to have is a very, very hyperacute presentation of discharge. So the discharge is very, very, very abundant. It's very purulent and creamy, all right? The patients tend to have even more severe eyelid edema. Usually both eyes are swollen shut in a very short period of time, and that is what scares the patient, the swollen shut eyes and the abundant discharge. And when you open up and look in, you will see a lot of chemosis. We know what chemosis is. Anyone can tell me what is chemosis? I'll just pause right here. Anyone wants to tell me what is chemosis? Anybody?
Swelling of the conjunctival.
Right, so chemosis is edema of the conjunctiva. Very good. So in this picture here, if you see my pointer, you notice that the conjunctiva is bulging outwards, right? So that is chemosis. And depending on how severe pathologies in the eye are, the chemosis can be even worse, to the point where you close your eyelids and the conjunctiva actually gets trapped between the eyelids. It can't close. And you can imagine that has its other set of problems. All right. So in this picture, I'm showing the chemosis here, all around here. So if you look, you see that the cornea is on one plane and the conjunctiva is bulging forward. Okay. So that is gonococcal conjunctivitis. Then you see that creamy, abundant discharge falling over the eyelids. All right. And when you look at the eyelids, you'll see the lid margin here, and it's very thickened, and the eyelids, upper and lower lid margin are thickened here. Okay. So that's an idea of what you see when you have a patient with gonococcal conjunctivitis. Now it's very rare. It's not as common as it was before. It's rare, but very significant. Okay. So gonococcal Neisseria gonorrhoeae has the ability to penetrate intact tissue. So what this means is that if you don't address the problem, the bacteria can actually go through an intact cornea and go further back into the eye, into the anterior segment, and cause other issues. So that's why you always have to look for corneal involvement in a case of, well, any case of conjunctivitis, but because it'll help clue you into how severe the bacteria is. But in Neisseria gonorrhoeae, you have to, it's one of the risk factors, okay? So you tend to, if the cornea is involved, you start to see corneal opacities and ulceration, so you have a corneal ulcer as well, all right? Now, you always try to swab these patients. So you're going to do your culture stain, your conjunctival swab, and you're going to send for gram stain, and your gram stain and culture and sensitivity. You can actually look under the microscope and see the diplococci, okay? Well, you, but the lab, and that's how you get the diagnosis. Now you have to treat these patients with both topical and systemic medication. So topically, we like to give intravenous or intramuscular works as well. You can give them 1 dose of ceftriaxone, all right, as a start dose, and you can continue with treatment with topical antibiotics. And that's how you treat it, with the same level of lid hygiene. And you always tell the patient to monitor for worsening, because it should get better and not worse. And remember that these patients, because it's a sexually transmitted disease, they can actually also have a vaginitis or a urethritis. So you can check that out in your history as well. And it's one of the diseases that you have to do contact tracing for. So it's a public health disease, it's a risk, so you have to report that disease as well. All right. So we're going to go on to ophthalmia neonatorum. There's a whole lecture on this. I'm just going to touch briefly on this. So any conjunctivitis that you find in a neonate less than 1 month old is ophthalmia neonatorum. And there are different entities that can cause it. Okay, so the common causes are, I've listed here below, a Neisseria gonorrhoeae, but you can have it from Chlamydia trachomatis. You can have it caused by streptococci, Haemophilus influenzae, and other gram-negative organisms. And you can also have it being caused by viral entities such as herpes zoster, herpes simplex virus, okay? Not zoster, HSV. So what actually happens is during the delivery, when the baby passes through the passage, the baby can get the secretions from the mother, the infected secretions into the eye, and that predisposes the child to then develop in that the first few days of life, that conjunctivitis. So the patients are always at risk of severe ocular as well as systemic complications. So that's why you have to diagnose it early, and that's why you have a little protocol when the babies are born, where they put on this the drops in the eye, the silver nitrate in the eye. But this is a reportable disease. They'll have about the same symptoms as the adults, but in the child, you have to be more careful, okay? So you have to diagnose these patients. You take your conj swab and you send up for your gram stain. You can have the lab look under the microscope and identify the diplococci, and then you can start your treatment with IV in the case of children. You can give them ceftriaxone as well in the dose per weight, per milligram, 50 milligrams per kilogram per day. And you also want to treat them with topical medication as well. All right. So there's a whole lecture on ophthalmia neonatorium, so I'm not going to go into that. I'm just going to mention the chlamydial aspect of it, where you can have a subacute onset within 4 to 28 days after birth in a neonate. And the discharge is also mucopurulent and very, very abundant. When you examine the child, you'll also see these eyelid signs of papillae, and the patient will have a lot of conjunctiva of eyelid swelling. And you want to make sure that as the ophthalmologist, you want to put in some drops to see what is going on in the cornea, because remember, it can penetrate the intact corneal epithelium and cause corneal ulcers, which can cause an endophthalmitis, which can cause other complications such as orbital cellulitis and brain abscesses. So in the neonates, it's very important to diagnose these diseases. Now, in terms of the other systemic problems, you can have the chlamydia, you know, that you can get your pneumonitis, your otitis, your rhinitis, okay? But essentially, hello? Somebody's mic is on? Okay, so moving on. So you want to treat these patients, and usually the treatment stems up to 2 weeks. Chlamydial infection is one of the infections that you get in childhood that can predispose you to a lot of scarring of the conjunctiva and further problems later on. So when you see an adult with conjunctival scarring, you can assume that it's because they had a chlamydial conjunctivitis. So that's one of the differential diagnoses for cicatricial conjunctivitis, okay? So we're going to move on to the more popular adenoviral conjunctivitis, which is the pink eye that we see, okay? So viral conjunctivitis, that is usually caused by adenovirus in 90% of the cases. Now I have to mention a special moment for coronavirus. We are probably all aware that one of the signs of coronavirus can actually be a conjunctivitis. And one of the the whistleblower doctor in Wuhan, China. This was an ophthalmologist who had actually discovered that there was an outsurge of coronavirus, right? So he didn't see it because the patient had a conjunctivitis, but I just have to mention him because, you know, he's one of the, he was there in the very beginning and he died with coronavirus. So essentially, it's not very common to have a, well, here we don't see that very often, but there are cases reported that you will have a conjunctivitis with coronavirus, and that can be one of the things that, because you can find coronavirus in the conjunctival secretions. So a patient can present like that, and we're on conjunctivitis, so I have to make you aware. So that's one of the reasons that we now use our gloves for our ophthalmic exam in the epidemic that we have, in the pandemic that we have now. So adenoviral conjunctivitis, very, very, very contagious, okay? The virus can survive on different types of surfaces for many, many days, and it can continue to have a lot of viral shedding before clinical features cannot be shown. So asymptomatic patients can still spread the disease, all right? So there are two types of adenoviral conjunctivitis, or two syndromes. One is called pharyngoconjunctival fever, and the other is the epidemic keratoconjunctivitis. That's the one that you see all the time. All right, so in the case of pharyngoconjunctival fever, it's because of the serotypes 3, 4, and 7, and you tend to have a lot of aerosol transmission found in children and adults. So these patients will tend to have a conjunctivitis as well as an upper respiratory tract infection, or they can complain of a sore throat. And when you look into their eye, you'll see all the signs of conjunctival disease. The discharge will be watery. You'll see You can also see the hyperemia of the conjunctiva, and in a 30% of these cases, you'll actually see corneal involvement. So the corneal involvement, remember, is called keratitis. Any lesions or inflammation of the conjunctiva is called keratitis. So you'll see a keratitis, and in 30% of these cases, all right? Then let me just pause because I heard a beep. Somebody has a question?
Yes, doc. The serotypes are for which virus?
Oh, the adenovirus.
Okay, okay. Thank you.
You're welcome. All right, let me try and go back to the full screen. All right, and let me get my laser pointer back. All right. So in the case of the epidemic keratoconjunctivitis, it's just a conjunctivitis where you have signs in the conjunctiva and you can have signs on the cornea as well. So it's direct contact, but 80% of these cases will have corneal involvement, hence the name keratoconjunctivitis, okay? So the majority of these cases will have corneal and conjunctival involvement. They don't usually have a history of sore throat or upper respiratory tract infection and that sort of thing. All right. And this is the one that is responsible for the epidemics of pink eye because it spreads so quickly because the virus can stay on surfaces for so long. If one person comes into our eye clinic, for instance, and we don't have good cleaning techniques, you find that everyone that we examine in that slit lamp will have the disease. Or somebody comes to A&E and they touch their eye and they touch something and somebody else touches it, and then everybody or a lot of people on that one day or a lot of people in a classroom can have this infection of the conjunctiva, and that's how it spreads. Or everybody in one household and that sort of thing. Okay, so that's why it's the epidemic type. That's why you get these pink eye epidemics. All right. So when it comes to viral conjunctivitis, examining the eye is a bit different. So the presentation can be anywhere from mild to severe, okay? But it's very uncomfortable. The patient will have a history of contact with an infected face, and they'll start with an acute onset of watery eyes. They'll describe a lot of burning, a lot of photopia, and depending on how watery the eyes, they can and how much discharge they have, they can actually have a blurring of their vision. All right. When you look at the examination of the eye, this is an example of the hyperemia I was trying to mention early in the lecture, where the conjunctival vessels are these, and it's a diffuse hyperemia. In a case of your adenoviral conjunctivitis, it's diffuse, okay, because these vessels become dilated. All right. Now this is the lower eyelid, so we do traction on the lower lid here, and you can actually see these round things. These are actually follicles. All right. So the difference between a follicle and a papule, the papule is surrounded by centralized by a blood vessel. In the follicles, you just have a raised lesion of edema. Okay. So you see follicles on the lower lid. You flip the upper lid, and you see follicles as well. So you tend to also swab. You send for your viral antigens, and you can send for your PCR. And unfortunately, with the pink eye, you tend to want to give supportive care because of the burning, the discharge, the running off. But because you have an adenoviral conjunctivitis, it doesn't mean that you can't get a secondary bacterial infection, okay? So the patient can get a secondary bacterial infection because people are always touching things, and then you have to add an antibiotic to the treatment. But normally you can use non-steroidal anti-inflammatory eye drops, such as Voltaren, to help with the pain and the discharge that the patient is having, and the frequent cleaning of the eye, not sharing the pillow, not the bed, trying to not touch the eye and touch anything. So frequent washing of the hands, frequent lid hygiene. So that sort of supportive care is what you offer a patient with a viral conjunctivitis, okay? Because you can't just give antivirals and let it go away. It's normally, what do you call it now? It's normally symptomatic or supportive care. All right, so this page was taken out of the Oxford Handbook of Ophthalmology, and it was just to kind of give a little contrast to you, comparing conjunctivitis of different entities. So in the bacterial, the eyes will normally be red, sticky, grittiness or foreign body sensation. They'll have an acute or hyperacute onset. It can involve one or two eyes. The patient will have a history of touching someone with infected secretions. Okay, so they will have touched somebody with a red eye. And the discharge is purulent. You have papillae, and you can have the lymphadenopathy. There's mild chemosis, but depending on the bacteria, remember we mentioned this, the chemosis can be mild or severe depending on the etiology. So when you look at viral conjunctivitis, this difference here is the discharge is watery, acute onset on the uni or bilateral presentation, and the discharge is watery here, okay? And they will have follicles and not papillae. The chlamydial, well, we talked about this, creamy discharge, there's a history of sexual contact, the discharge is mucopurulent, and you've got follicles as well. I just put here the allergic conjunctivitis. If you look here, there's itching in the history or the symptoms, okay? So I'm gonna go on to that one next, but in allergic conjunctivitis, the main symptoms can be itching, redness, you can have the eyelid swelling as well. It can be bilateral. It's usually in a patient that has a history of asthma or a history of atopy, very sensitive, very frequent rhinitis or sinusitis. And in allergic conjunctivitis, the discharge is watery or it can be mucoid as well. And when you flip the lid, you see papillae. All right, so I'm going to go on because that was just a snapshot. So allergic conjunctivitis is extremely common. It's very seasonal, and to be quite honest with you, it never actually completely goes away, okay? So allergic conjunctivitis is caused by all of these types of conjunctivitis. The allergic is caused by a type 1 hypersensitivity action. So the patient complains of an acute onset of, or acute or subacute onset of watery discharge, redness, itching. Some people describe a lot of foreign body sensation, and this is why, okay? When you look at the next picture, the patient will also have chemosis of varying degrees, so it can be mild, moderate, or severe chemosis. The patient will have eyelid edema, and when you flip the upper and the lower lid, you'll see papillae. So you will see the edematous zone centered by a blood vessel, okay? Now in this picture here, this is a patient with what is called vernal keratoconjunctivitis. So you have these cobblestone giant papillae, and they're centered by blood vessels. And that's a different type of, that's a more severe kind of allergic conjunctivitis. Vernal keratoconjunctivitis, or VKC for short, is a more chronic form of allergic conjunctivitis, okay? And when you flip, you see these cobblestone papillae. And this now can, when the patient blinks, can actually scratch the surface of the eye and cause corneal ulcers, okay? Because it's constantly resting on the eyelid. You know, the upper eyelid, it usually rests about 2 to 3 millimeters below the superior limbus, and the lower eyelid rests just about at the limbus here, okay? So that can cause corneal ulcers in VKC, all right? That's a very extreme form of allergic conjunctivitis. So moving back to the regular allergic conjunctivitis, when you flip the lid, you will see papillae on the upper or the lower eyelid, and that clues you in. The patient here, that's a very nice description again of what chemosis looks like. This is a slit lamp examination, and you can see that there's some depth to the conjunctiva, so it's not flat and on the same plane as the anterior surface of the cornea. So you'll see the conjunctiva bulging. All of that is a fancy term for it's bulging, and it's edematous, okay? And you can appreciate the diffuse dilation of the conjunctival vessels here, all right? So you can identify the allergen, but in circumstances, I think that allergens are everywhere. So it's really hard to pinpoint because you've got a lot of dust in the summer, you have a lot of roads that are not paved, or people living in farming areas. So it's very, very difficult to identify the pathogen in these cases. Sorry about the phone. Right, so you tend to want to treat these patients with eye drops, okay? You can give them mast cell stabilizers. We have antihistamine drops, cyclosporin, all of these things are to reduce the immune response of the patient. And we also need to give the patient medication for dry eyes. So you give them lubricant eye drops as well. Because remember, they will have a lot of gritty sensation or foreign body sensation. So So you give them mast cell stabilizers, antihistamines. You can give them lubricant eye drops as well. It helps a lot with these cases. And you also have the option to give systemic antihistamines as well. All of this is to reduce the immune response. All right. So we are going to move on to corneal degenerations. There are main degenerations that I'd like to talk about. The pterygium and the pinguecula. So the pterygium is this here, okay? So it is a triangular, I'm going to draw here, fibrovascular subepithelial growth caused by degeneration of the conjunctiva. So sunlight causes it, UV exposure. So you have the upper and the lower eyelid, and in that space you find the bulbar conjunctiva here. And because of the exposure to the sun, you tend to see these changes occurring on the level of the conjunctiva. All right. So right here you can see on the other picture that it's a bit more of a nice triangle here, but it's all the same. I want you to say it's a triangular fibrovascular subepithelial growth caused by degeneration of the conjunctiva. Okay, so it's elastotic degeneration. It's caused because of sunlight. And normally you'll have a pterygium extending over the limbus. Okay, so this is the lid here, the corneoscleral junction, and the conjunctiva goes to degeneration and it continues to spread across over the limbus onto the conjunctiva. Okay, now if you notice here, the pupil is here. So at this point, the pterygium right here has reached the visual axis and it will cause a decrease in the patient's vision. So hopefully we want to get it before it gets to that point. But unfortunately, I still have patients come in with it at that level. Okay? So the risk factors, as I mentioned, are ultraviolet exposure and a lot of surface dryness. Now, in the pterygium, it penetrates onto the cornea and it actually invades Bowman's layer. So when it gets to Bowman's layer, it means that anything we do to remove it, you're going to have a corneal scar. So this is another reason why we want to go ahead and treat a pterygium before it gets to this point. And there are various methods of treatment that I'll tell you about. Okay, so it invades Bowman's layer of the conjunctiva, encroaches onto the cornea, and it's a triangular fibrovascular lesion. Okay, so that's what a pterygium is. So in thinking about pterygium, it can be asymptomatic, meaning that you're walking around and there's no knowledge that you have a pathology. All right, it can be asymptomatic until you look in the mirror and you see it, or most of the time people looking at you will say, what is that you have in your eye? Okay, so it causes irritation, it causes foreign body sensation, it can have pains where you get an inflammatory response, so the eye will flare up and there'll be redness right at the location of the pterygium. That would be localized hyperemia, localized redness in the eye. Okay, and if it's there for a period of time and it encroaches on the visual axis, it can cause a decrease in your vision, but it can also, without reaching your visual axis, cause an astigmatism. Okay, so it changes the curvature of the eye and it can cause an astigmatism. And that sometimes can make it very difficult to give a patient glasses because of a pterygium. Okay, so how do you manage a pterygium? So when you talk about management of anything, you always have to go into prophylactic, medical, and surgical. Okay, so don't just jump into surgical treatment. You have to say that you can manage the patient by prophylactically by trying to avoid UV exposure. You want to tell the patient to wear these UV sunglasses. So when you have UV sunglasses, you have them in either 100, 200 or 100. If you notice when you buy eyeglasses in the sunglasses in the pharmacy, pay attention to the UV message. If it's not on it, then it doesn't have it, okay? Because once it has UV protection, it will have a sticker on the sunglasses. So I tell the patients to look for these types of sunglasses with which prevent UV exposure to the eyes. Now, another way to treat it medically is to give the patient treatment with lubricant eye drops. If the patient gets various modalities of lubricant eye drops, you can give them eye drops, or you can give them gels. Okay, so the gels in the eye are when the patient has a lot of severe dryness. The patient themselves will say, my eyes feel dry, and they'll have a lot of watery eye as well. That's another thing that tells you that the eye is dry. The eye will water when it's dry. So you give them lubricant drops. You can give them in various frequencies, maybe every 2 hours if it's very severe, or you can give them every 4 hours, or every 6, or every 8 hours as needs be. I tend to give eye drops during the day and gels at nighttime while the patient is sleeping, so that when they wake up in the morning, their eyes are nice and moist, because drops and gels will form a film over the eye and they might decrease the patient's vision. So I tend to give lubricant drops during the day and gels and ointment at night. Okay, so let's move on to the surgical treatment now. What are the indications for removing a pterygium surgically? The number one indication is cosmesis. Okay, well, I would say number two, sorry. The number one indication is a decrease in the vision. So you can imagine if the patient has a pterygium in the visual axis, that needs to go. So you try and encourage the patient to remove it because it's affecting the vision, number one. Number two, they will have a corneal scar, all right? So these are two things why if it's in the visual axis, it needs to go, all right? So that's the number one indication, a reduction in the vision. Number two, cosmesis. Another indication is if you've done it before and it reoccurs. So a recurrent pterygium has to be removed surgically. And number four, a very symptomatic pterygium. It may be small and not in the visual axis, but the patient presents with recurrent episodes of inflammation at that level of the pterygium, or they tend to get an abrasion right there at that spot because the pterygium is no longer a flat surface. It tends to be raised. And over that raised surface of the pterygium, you tend to have a lot of evaporation of the tear film. So that's why you can get so dryness and irritation in the eye when you have a pterygium, okay? So if it's very symptomatic, they can get an abrasion, they can get that excessive dryness of the eye, excessive redness and irritation, and that's another indication on when to remove it surgically. So there are a couple of ways that we can remove or excise a pterygium. All of these modalities here are good. The problem is that this one is just a simple bare sclera approach where we just lift it off of the conjunctiva and take it off and don't do anything with it. So that's called bare scleral excision, and it has an 80% recurrence rate. So I don't tend to do this anymore because some people have been successful, but there are patients who maybe after 5 or 10 years, or some people after 3 months, that they'll come back with the lesion like this, okay? So surgery is one thing and the medication after surgery is another. Both of it is important. And the third factor you must never forget for the patient, you have to reduce the irritation in the eye. So the patient should have UV protection and they should always have lubricant drops, okay? Because these are some of the factors that cause it to. So you want to reduce that as much as possible. So the next approach that we'll look at is a conjunctival flap. So you do your simple excision and then you rotate the conjunctiva in such a way that it covers the area where the pterygium was. That tends to be a little less frequent, cause a little less recurrence, okay? Then the third procedure, we can do a conjunctival autograft where you remove the excision with procedure number one, and then you take some conjunctiva from a different part of the eye. Usually we could use the superior limbus, the conjunctiva at the superior limbus, and we relocate it to that area where the pterygium was. I don't think I mentioned, let me go back, that a pterygium normally occurs at the nasal or the temporal limbus, okay? So it can occur at the limbus between the upper and the lower lid. It usually occurs in the clock hours 6 and 9 o'clock. It's more common in the nasal limbus. So if it's your right eye, this will be common at 3 o'clock. If it's your left eye, it'll be common at 9 o'clock, okay? But it is common in the nasal limbus, and it can occur in the temporal limbus, but it's more often seen in the nasal limbus. So when it's in the temporal limbus, you kind of want to differentiate from either a pseudopterygium or a foreign body granuloma or other things, or previous history of chemical injury in the eye. These are things that will cause pseudopterygium, okay? But the real pterygium, that's what it is. So in terms of the location of the eye, we take the pterygium out. Let's say we're talking about one at the nasal limbus, and we replace that area where there's no tissue now with conjunctiva from the superior limbus. All right. So we can also replace it with an amniotic membrane patch graft, and because amniotic membrane has a high level of tissues that can grow into lots of cells. So we can replace the membrane with an amniotic patch graft, which can be a dry graft or a wet graft implanted. We actually suture it or use special glue to put it in that location where we remove the pterygium. And it sort of forms a bridge so that the base of the pterygium, when we excise it, doesn't just grow all the way back. So I'll go back to this picture here. It's a triangular lesion where you have the apex of the triangle on the cornea and the base of the triangle towards the sclera, on the sclera, okay? And another thing that we can do is use these this adjunctive, all right, to reduce the healing process. So you tend to use mitomycin C. In the old days, we used to use beta irradiation therapy. We tend to move away from that because chemical agents such as mitomycin C tend to work better and are longer lasting. So we tend to use these adjunctive therapy to reduce the rate of recurrence in the pterygium, and they work very well. So moving on from a pterygium to the important degeneration in the eye, we have the pinguecular. So the pinguecular is not a triangular-based lesion, okay? The pinguecular is also caused by sunlight exposure, so it's elastotic degeneration of the conjunctival stroma, and it's just adjacent to the limbus. So it does not go over the limbus onto the cornea. It does not invade Bowman's layer, all right? You tend to see it as little yellowish white deposits on the bulbar conjunctiva, either at the 3 o'clock or the 9 o'clock position, all right? And it tends to be just a little raised area here, and normally it tends to stay just as it is. All right. So because of the fact that it is adjacent to the limbus and it's an elevated lesion, you can also have these symptoms of burning, dryness, foreign body sensation. And when you look into the eye, you see that lesion right here. It tends to grow very slowly, and it's usually most times asymptomatic. The harm that a pinguecular will do is that it can become abrased, as in the epithelium can get scraped off and it can cause irritation at that point in the eye, or you can actually get dry eyes, all right? And in that case, we tend to want to treat it with lubricant eye drops. If there's an abrasion, you tend to want to use some antibiotics because the patient can get an infection secondarily, but most of the time we manage the pathology with topical lubricants, okay? And we're going to move on now from the degenerations to the entity of subconjunctival hemorrhage. Okay, so a subconjunctival hemorrhage is now a localized area of redness in the eye. Okay, so if you see that, you can actually describe it as a beefy redness to the conjunctiva. So it's usually idiopathic. So a patient will come in very concerned and say that their eye is bloodshot. But when you take a look now, you see it's a subconjunctival hemorrhage. So you want to do a history and a physical exam on these patients. So it's usually spontaneous. They wake up in the morning, they don't know what they did, right? And they see the eye red, or they go to work normally, and then people start telling them that there's something wrong with their eye is very red, all right? So the other causes of a subconjunctival hemorrhage, because it's idiopathic normally, but you can have it being caused from trauma. The patient can hit the eye or even scratch the eye on the pillow. You can have it induced by surgery. So if we do cataract surgery, my patients tend to have a subconjunctival hemorrhage because of the site where I do the anesthetic, or right where we do a cut on the eyeball to get into the eye itself, okay? If a patient has an episode of coughing, they can rupture one of the vessels, and you can have a subconjunctival hemorrhage. Anything that increases the Valsalva maneuver, like puffing or vomiting or straining to defecate, all of these things can cause a subconjunctival hemorrhage. Now, you can also have to rule out systemic diseases, especially in the elderly patients. Their high blood pressure, pressure can shoot up, systemic vascular diseases, and you also want to rule out what are the blood dyscrasias. Okay, so these are some of the things that you want to rule out. If there are blood dyscrasias, you won't just get the subconjunctival hemorrhage there. You'll also get you'll get hemorrhages on the retina as well. So you want to do a dilated exam on all of these patients to look and see the eye in its entirety. You never just look at the patient. You won't just look at the anterior segment or the outer surface of the eyeball. You want to dilate these patients and do a thorough medical examination. In treatment of the subconjunctival hemorrhage, it usually resolves spontaneously. So you do not need to treat these patients. After I give my patients up to 14 days. Some people take a little longer, give or take, but usually in 14 days it tends to go away. So you tend to just reassure the patient if you don't find anything. And in worst case scenario, I would just give lubricants because patients usually describe the eye feeling weird. All right, but once you rule out infection, and inflammation, a degeneration, blood dyscrasias, any maneuver that increases the Valsalva maneuver, coughing, straining, that sort of thing. Once you rule out all of the grotesque etiologies, then you can reassure the patient and just give them some lubricants if they insist, but you don't need to give anything. So don't prescribe steroids, don't give anything, just give them lubricants, okay? So that I think is the end of my lecture. I'll open it to any questions. You guys have any questions?
Hi, Doc. What was the
Mm-hmm.
other name for the subconjunctival hemorrhage? A beefy red blot or spot?
It's just a beefy redness of the conjunctiva. It can be localized to a certain region. So if you notice in the picture here, it's actually localized to this zone here. And what tends to happen when it starts off as a little small spot, and because there are no septae or divisions in the subconjunctival space, if it starts, for instance, at this zone, it's not going to stay there. So it starts small and it will start to spread because there's nothing limiting the spaces there. So it tends to get a little worse before it gets better. And if you notice in the picture, there's one coloration here. You notice that's a little yellow, a little clearer, as opposed to inferiorly here. That looks like when it starts to color, it changes color. So with deep red, then it gets a little purple, then it gets a little yellow, and the yellowness spreads. And as it loses the heme in the bleed, then it starts to change color and clear up little by little. So it's just a beefy redness of the conjunctiva, or patients can describe it as a bloodshot. You know, it's like a little bloodshot place in the eye. Just like when you get punched in the eye and you have a ecchymosis, it's the same theory because orbital trauma, a punch in the eye, basal orbital floor fracture, or any type of orbital fracture, you can see a subconjunctival hemorrhage too. All right. Surgery, a cataract surgery, glaucoma surgery, a squint surgery. In squint, you know, we operate on the muscles, so you see a localized area here of redness, redness. It depends on the patient in front. So it can be a diffuse redness based on the pathology or the etiology, or it can be a localized redness. For instance, if I gave the patient antibiotics right in that spot under the conjunctiva, then that's where it will be and stuff like that. So the history is what determines, and the way the patient presents will actually determine the architecture of the hemorrhage. All right. Any other questions? So these are all just a prelude to your studying, guys, okay? We can never give you all the information that you need for all the topics in ophthalmology. So you have to do some more reading. My aim is always to percolate your brain cells, to just titillate your brain cells and just stimulate them. So I tell you the topics that are important and relevant, give you some information, and you go and read it, because I find that you are, as a medical student, you consolidate things better when you read them, okay? So in looking at the different, you need to do some reading on this topic. I've had people in exams say, oh, I've never heard of a pterygium. It could be like 5 minutes when you're in the lecture and you just doze off, or you just look away and boom, that's what comes in your exam, or that's what comes to you as a patient. Okay, so remember that in medicine, everything is important. It's impossible for you to remember everything, but the highlights of the lectures are to give you the points that you must remember. Okay, because you will have a relative with a tumor or pinguicular. You will have somebody who has a conjunctivitis. You will have somebody that's complaining that the eye is swollen and red, and you don't want to confuse a preseptal cellulitis with an allergic conjunctivitis. So the history is very important. Next, your physical examination. Know the signs and the symptoms of conjunctival disease, and that will clue you in to what is happening with the patient. And then look and do your reading. Look at some pictures. I've tried to give a lot of pictures in the lecture so you can get an idea of what things look like. But this is just the prelude to what you're going to do when you do your reading. Read it now. You never have to read it that hard again. All right. So any other questions? All right. So I'm going to just come out of my screen sharing and well, let's stop screen sharing and go to you guys. All right. So if there are no more questions, I will actually end the lecture. All right. So I think my next lecture with you, I will apologize for last week. We missed the uveitis. I wasn't feeling well. So we have rescheduled that one for, I think it's the 8th of October. All right? All right. So thanks very much, guys.
Thanks, Doc.
Thank you, Doc.
All right. So do some reading. Thank you and goodbye.
Thank you, Doc.
All right then. Bye.
Thanks, Doc.
You too, guys. Stay safe and COVID free.